I observe protocol, and in a special way, I also want to thank the PS for gracing us this morning and to be with us this morning as we begin this very important conference. It's been a journey, and our report, this is our 7th edition and published edition of the National MPDSR report, and I think we need to clap for ourselves. So very quickly, you'll need to move these slides quickly. Those are acknowledgements. We acknowledge everyone. Next. Just a focus on the objectives. We are focused on documenting the data-driven healthcare system response for improved maternal and perinatal outcomes. And the specific objectives to describe the magnitude and trends of maternal and perinatal death mortality, to describe the causes and avoidable factors associated with maternal and perinatal causes, to provide accountability in form of data-driven response, to document best practices in form of success stories and case studies in MPDSR, and to assess progress towards implementation for the financial year that. Very importantly, we added a strong component of accountability for results. This is our journey, the roadmap. We've been able to move. Those are the 7 publications that I talked about. Those who remember, our first number 1 looked like that, number 2 looked like that, and they're all available in stock. They are online on our portal, the knowledge portal. Number 3 looked like that, number 5, number 6, that's last year, and the recent one, this is our 7th edition. A very beautiful journey. Next. Yes. Our emphasis is using data. Our emphasis is using data to guide decision making. And here we are. We are not 100% there, but we are making progress. We captured a few of the national level achievements that we're able to achieve. At national level, we are proud that the Ministry of Health has continued to provide leadership and coordination through the weekly national MPDSR meeting. Thank you, everyone in here. We clap for ourselves. At the beginning, you asked for data, but now you tune on without asking for data. What a change in attitude. Thank you so much. We conducted virtual dissemination of the EMOC and NC model guidelines through monthly national meetings. These have been well attended, Madam Chief Guest, and with over 500 participants attending, and they are happening on a monthly level. At subnational level, we've been able to establish and operationalize local maternity and neonatal systems with your guidance. This was your brilliant idea, Madam PS, and we ran up with it, and it's doing wonders. Regional dissemination of the MPDSR reports in regions at regional level. We want to acknowledge the partners who supported us to do this. Conducted regional dialogues among critical MCH critical cadres. We also have routine, we call them doctors' dialogues. We engage doctors. If there is a problematic region, we've had one for West Nile because there was really serious problems. I engaged doctors in a doctors' dialogue. Even in Bali, if it's represented, we had a dialogue here. Service delivery level, this has been mentioned, and with your guidance, we've been able, Ministry of Health has been able to upgrade these 81 health facilities, and we are visiting all of them to see what the needs are and make them functional. There have been also an additional 369 facilities under UGIFT, but it's not captured here. Adolescent Health has been able to provide 369, the numbers are right up there, to offer adolescent responsive services, to strengthen the referral system by utilizing social media to coordinate. The different local maternity and neonatal systems that are doing a great job. Madam PS, they are coordinating referrals. And I loved one from Kabale. I think Good Luck, someone called Good Luck. I don't know if he's here. But yes, Good Luck, I can see you at the back there. You coordinated, let's clap for him. He coordinated a referral from the island, and we had very good outcomes. I saw it on social media. I also didn't know how he did it. Developed an in-service training package for neonatal nurses to build capacity in newborn care. Madam PS, this has just been concluded. But I also want to say that SEED Global Health has committed supporting the curriculum approval processes for neonatal fellows. So Seed Global Health, thank you so much, Alan. We had a discussion about this. Establish UI collaborators, support identification. This is one of the most exciting things that I think is a magic bullet. Oh, it has disappeared. Can you just a minute? Yes. Madam PS, we have initiated, this one probably we've not briefed you. We have all the health center force and general hospital, CMOC sites conducting high-risk clinics. We realize that all the mothers who die in our health facilities have had an interface with the healthcare system at any one point. But we miss them. We don't follow them up. We don't do proper risk identification. But now we have started proper risk identification at the probably BMOC site. And then there is a referral. It's called IRR, Identification, Retention, and Referral. And we think if this is well implemented, we shall be able to identify and be able to appropriately manage all high-risk mothers identified early enough. At community level, we've mapped TBS to act as referral agents and companions to mothers and provide referral feedback. This is well done in Busoga. But I'm also happy that RDCs, I saw one from Namutumba, have been active now to close them down. Utilization of RDCs on radio time has been done. Rollout of Family Connect program. This is mostly in the Busoga area. Next. Medicines and supply. It has been a challenge of medicines and supplies, but on the good note, we've been able to train our healthcare workers on perfine citrate in managing preterm babies. The introduction of carbetocin and tranexamic acid, though we don't have money yet to buy, but we've finished all the details. It has been enlisted in the essential medicines list. We've had all the other processes for introduction of these drugs underway. Under the PAPF framework, with partner support, oxytocin was availed to selected private facilities. We had an excess of pitocin procured through ANFPA in the year under review, and we managed to give everyone who wanted, whether private or whatever. We supported 42 health center force, supplying them with theater equipment and blood transfusion services to enable them to deliver CMOC, and now we have moved our percentage to 64%. At subnational level, procured and distributed newborn equipment to Bolisa. Next. We've been trying to capture everything that is happening. We are also happy for your efforts to drive the new human resource structure, and we hope you'll continue to fight for us as we get more funding to implement it. Conducted monthly CMOC webinars. This is capacity building to bridge gaps, and we've also supported any region if they approach the National NASMEC Secretariat that they need a special seminar, let it be on the use of misoprostol or IV fluid resuscitation. We've been able to support that. Subnational level training, mentorships for knowledge and skills enhancement and ITO have been carried out. Oriented health workers on provision of adults and health. Next. There's been engagement under financing of the Corporate Society for Safe Motherhood. This is also your brainchild. And thank you so much, Stanbic. I know you're already in the house for really pushing this hard. You recently also gave us more equipment and mama kits. We also want to thank Rotary. Rotary is in the house. Rotary has pledged to give us 300 tricycle ambulances. Can we clap for Rotary? They've not only pledged, but they've already delivered 68 tricycle ambulances. Thank you so much, Rotary. Madam Chief Guest, we still need to thank you. Rotary TVS have been waived of taxes, and we don't have any trouble from URA. They are coming in tax-free to help the mothers and the newborn, and the reports that we're getting from the field are commendable. MOH has advocated for increased funding for parliamentary. We've had an engagement with the parliamentary group, especially the Health Committee of Parliament, and the chair was calling me, is coming for this meeting. Next. Health information, we've really done a lot. There's been dissemination of the weekly MPDSR analytical products with RAMNA, printed and distribution of the MNHHMS tools, dissemination of the MPDSR learning at international level. I think we are probably one of the leading countries on the continent on MPDSR. And I've been informed that next year, Dr. Olive, is it next year? Dr. Olive, yes, next year. The global MPDSR meeting will be in Uganda, March next year. and that was chosen by WHO. Conducted integrated quarterly regional performance review meetings. We rolled out Ramnak scorecard in Acholi and Busoga. Next. Yes, now, the meat. I think we've been in the bones now, fascia. We've been in fascia later, now real tissue here. Here we go. Just look at this impressive trends in institutional perinatal mortality. We are moving down. Here we are. We are 2022. Thank you, everyone. But we still have work. In Swahili, they say, tuko na kazi. So we still have work. We seem to be plateauing. Most energy might be needed here. We need to do some things extraordinary here. But majorly, it's the quality of care. We shall probably summarize. Next. This report will be available today in hard copy and soft copy. It has been fully signed off. So these are details of where most of these perinatal, institutional perinatal mortalities are happening. So our leaders, our stakeholders, you'll see actually now, to be very specific, we still have, I'll draw your attention, I love the stillbirth. These are things that we can eliminate. Kampala still has the highest stillbirth rate. Dr. Biarhanga is fighting so hard. Bunyoro still has the highest stillbirth rate, fresh stillbirth rate. Because these are within our means. They kind of depict that we can do something faster. We are losing some golden moments. The rest of the details you'll be able to internalize. Institutional perinatal mortality, the map here, I don't know if it's clear to all of us. 82 districts, that's 56.2%, had reported institutional perinatal mortality below 15 per 100,000. That is what we want. 18 districts, 12.3 recorded above 25. This is an issue, but you realize when you go down in the details, you realize that are happening either way. There's a general hospital that's very busy or a regional referral. Quality of care. Most high burden districts lack MNH support partner. That's really an issue. Partners, we need to rationalize and align. Perinatal mortality rates by level of health facility. Not surprising that general hospitals, regional referral, and national hospital. This is not surprising because the referral system, it also speaks that our referral system is working. If we found them dying down here, we would have a trouble. So I really think that the highest rates are at national referral hospital, where the highest births are, and the highest stillbirth it's a trend. So macerated also highest as at the national level. So this detail can also be internalized, and we shall have regional disseminations. Trends, the trends here are telling us where we come from, also per region, and notifications. We recommend that we should have every perinatal death notified and also reviewed. Review for perinatal death has remained a challenge, and as you can see, the review rate, those in red, less than 25%, those in yellow, above 25%. So for review, you'll see that green above 50 are few. Are increasing actually, Madam PS. Given what we had last year, I wish we would show you a comparative analysis with last year, but this is progress. I think we clap for ourselves. Progress. Perinatal deaths reviewed and reported. If you can see yourself where you are, I think this is just a map calling for action. We need to thank these guys here. These guys here. Well done. And it's not by surprise, Madam PS. These guys here in Kigezi, I think their health system is very strong, very strong. I don't know who is this outlier. Could it be Toroko? Could be Toroko, an outlier, but well done posting a green in a sea of red. Green Acholi Lango, and you'll hear on the last day, I have a feeling they could be the best performing LNMSs, these ones. At least I voted for them. These two, I don't know who will finally win, but one of them must win. 36 districts reviewed over 50%. The summary is over there. Next. Causes of death among the reviewed neonatal death. What is killing our newborns? Category name and, oh, you're very fast. Go back slightly, please. So, the leading cause, birth asphyxia still remains the leading cause of neonatal death within 0 to 7 days. So that is the killer, and prematurity, of course. It has remained, it is still the killer. Next. Decision to incision interval. We are able, this is a quality indicator. We want to monitor how long it takes for our system to respond. It's a measure of responsiveness. Majority of the fresh stillbirth, 68%, and the early neonatal death, 58%, were delivered in more than 1 hour. We would recommend a decision to be done within 30 minutes, but this is more than 1 hour. 38% of the fresh stillbirth and 28% of the neonatal death were delivered in less than 30 minutes. So we were trying to categorize what are the factors outside the facility. So if it's more than 1 hour, those factors are within the facilities, less than 1 hour factors slightly outside the facility. And this is the graphic illustration. Next. Perinatal death reviewed by birth weight. As you can see, most of our perinatal death, the fresh stillbirth, 19 of them. We have macerated 11, early neonatal death 13, and you can see where most of them, the macerated 41, were between that age. These are actually mature, and these ones are all mature. They could survive extrauterine if we did more intervention to save them. The highest percentage, 57% of perinatal death occurred among the normal weight, above 2.5. That's the point we're trying to mention. Among the normal weight babies, the highest percent, 74, was attributed by fresh stillbirth. We have work to do. Tuko na kazi. Next. Pathograph use, also a quality improvement indicator. We are really focused on improving the quality of care.